Good afternoon, everybody. It's such a pleasure to join you today. This is interesting. Setting one's water on the sliding scale is going to be a little tricky here. So, very nice to join you, and I'm very interested as we present briefly on these topics to hear your discussion and your ideas, what's working in your localities and states, and to really share solutions here, because I by no means, nor does CDC, pretend to have all of the answers to these very difficult issues. I'll be presenting about some of the data that we have and some of the solutions that we're seeing work around the country, but these are areas that are going to take a lot of exploration and a lot of creative development. And we would very much like to learn from you, and as we do, spread what we learn from around the country with others. I'm going to start here. And a lot of these slides, I hope you don't worry too much about not being able to read the fine print. But I'm going to be talking about some gestalts in front of you. And these slides will be available to you as well to kind of look at the finer points. But this particular gestalt shows life, shows, and I don't know here. Okay, shows life expectancy in developed countries from highest on down, and the United States sits here with a life expectancy of about 27th compared to other developed countries around the world. Unfortunately, in achieving that life expectancy in the U.S., when we look at this line, which is the per capita expenditures that we spend on health care in the country, to achieve this level of life expectancy in the U.S., we are spending far more than any other country in the world. The gestalt here, I think, is one that speaks to the issue of whether we're going to be able to purchase our way out of very serious health conditions, to not only maximize life expectancy, but to maximize quality of life and optimal health for Americans. It does not appear that we're going to be able to spend our way out of that problem. And what I'm going to be talking to you about today, from my perspective and that of CDC's, are some public health strategies that work to maintain health in the first place, so that a lot of these expenditures can be avoided and we can promote optimal health while actually spending less. So why are we talking, obviously, about chronic disease here today? Nearly half of Americans are living with at least one chronic disease, if not multiple. 44% of Americans have one or more chronic diseases, representing 128 million folks. So this is not something that is affecting small portions of our population, that is, completely geographically or racially or age defined. These are problems that are hitting the population at very large numbers, and suggest that we need to do something upstream to maintain the good health we're born with. So what are the leading causes in the country? Top, of course, is heart disease, and close to that is cancer. 75% of all deaths in the country occur because of chronic illnesses, and most of those fall in the territory of heart disease and cancers. But sort of the iceberg under the water is not even just the premature deaths that occur due to these diseases, but the impact of these diseases on quality of life and issues of disability and the ability to engage in daily living activities, to be productive at work, to be able to do what you want to with the kids and the grandkids. But unfortunately, although not all of these chronic diseases are killers, they do impact very substantially quality of life issues. Arthritis is the #1 cause of disability in the country, with 1 in 5 persons living with arthritis. Stroke has left 1 million Americans with very serious disabilities, so serious they can no longer perform tasks of daily living. Heart disease is the leading cause of premature permanent disability in the workforce, and diabetes serves as a leading cause of kidney failure and new blindness in adults. We also see in these illnesses and conditions very substantial health disparities. Heart disease death rates are 30% higher for African Americans than whites. Stroke death rates are 41% higher for African Americans. Diabetes is quite high among American Indians and Alaska Natives, among African Americans and Hispanics, somewhere in the vicinity of 1 to 3 times the rates for white Americans. And as we started the presentation looking at the health costs that we're spending per capita in the country, we understand that chronic diseases are extremely costly. They account for about 75% of the $2.2 trillion of annual U.S. medical costs. And of course, those costs are deeply experienced by the Medicare and Medicaid programs, with 96% of Medicare spending going toward persons living with chronic conditions, and 83% of Medicaid spending going for that care. So I showed you earlier the leading causes of death here, the counts in terms of heart disease and cancer weighing in on the leading causes of death. But from a prevention standpoint, if you want to get in front of these issues and delay these illnesses as long as possible, and if we can delay the initiation of these illnesses into the 70s, 80s, and 90s, the kind of heroic medical care that goes on does not occur in those ages. And so you, in essence, sort of shorten the amount of morbidity by delaying disease as long as you can, live healthy, well, and active into the 80s, and rather than getting chronic illness in your 20s and 30s and having to deal with that from a quality of life and a care perspective for multiple decades. So when we look at how do we get in front of these chronic care conditions, we look at what are the preventable causes that underlie these issues. And it really is a fairly simple perspective. The actual causes of death then underlying these leading causes of death are tobacco use, and a very close second, the combination of poor diet and physical inactivity. Consumption of alcohol falls way back. So I'm going to be talking a fair bit today from a public health perspective about how we can prevent, delay, and reduce the costs associated with the leading causes of death by focusing on issues that we can indeed prevent in the case of tobacco and promote in the case of healthy nutrition and physical activity. So again, another gestalt here. I'm just going to talk a little bit about tobacco use in this country, which you can see right here had a very, very swift uptake through the 30s, 40s, and 50s. The peak right there reflects the time in which the 1964 Surgeon General's report on tobacco and all the relationships between tobacco and ill health were released. Now that report may or may not have been the cause of these changes, but it alerted the nation to the seriousness of tobacco consumption, and a variety of things took place at that time that resulted in this steep drop starting in the 60s and down to the present day. But what I want you to also see, not surprisingly then, is as you see the drop in tobacco use occurring just in front of the drop in lung cancer death rates for men following form right along those tobacco findings, and women had slower uptake, but it starts to peak and turn down as well. So it just kind of connecting the dots to saying that tobacco as an underlying preventive cause has a direct one-on-one relationship to the amount of disease, the amount of treatment, and the like. Unfortunately, as you know, the tobacco rates have leveled, and we have about 20% of adult smokers in the country. And basically, we're not seeing continued success in that area, although I do believe we know what can be done, and I will talk a little bit about that. Similarly, looking at what the impact of obesity is, I'll show you in a minute some visuals that show the relationship of obesity to diabetes in this country. But if you look in, these colors represent the percent of adult obesity in the states at the given time. A lot of the states in 1990 were in light blue. That represented less than 10% of adult obesity at the time. These navy blue states here that you can hardly see in 2000 and the beige states show us that by 2000 states were either in the 15 to 19% rate or in the 20 to 24% rate of obesity. And by 2010, we don't see any blue anymore. We see very little beige, and we see instead states entering the range in which states, in many cases in dark red, are higher than 30% of adult obesity, and not a single state in the country is below 20%. So these changes are occurring rapidly, and unfortunately they relate pretty much one-on-one directly as we look at our obesity changes over time as it relates to the uptick in obesity rates in the country. So once again, the underlying preventive factors that we can focus on are driving disease, driving earlier disease, and driving costs in the country. Not to leave the children out, to be sure, we've seen considerable increases in overweight and obesity among children, one line showing ages 6 to 11 in red, and the older pre- and teenage kids in yellow. The good news here is both the adult and youth obesity rates have begun to stabilize and flatten. We've seen no increase in recent years, and actually last month we were able to report a small downtick in 19 states and 1 territory among preschool-aged children in terms of obesity, ages 2 to 5, and these were low-income children, mostly coming out of measurement via their participation in WIC programs. So a very nice thing to see that we're not only leveling in some instances among adults and children, but have just the very beginning indications that we may be seeing some success in this area. Granted, those changes are extraordinarily small, but they're the first downward tick in obesity that we've seen in a generation. So I want to just alert you to this gestalt, which is something called Sortable Statistics. And if you simply pick up the slides and get the information, or just Google Sortable Statistics and CDC, you can get information for your state. Just pick your state. You can get information about every leading cause of death, every underlying preventive risk factor. You can compare white, black, Hispanic, you can compare men, women, you can look at different ages. You can pretty much sort and compare yourself in range of other states in your region or across the country or to national figures just by literally playing with this one data set. So if you want to look at where you fall on all of these health outcomes and preventive factors, it's a super easy way to get the data and compare yourself with others around the country. But we're really here to talk about what the opportunities for health in the country are, and in particular from my background in the public health arena. And I think we all recognize the need for engagement and different kinds of engagement at national and federal levels, at state levels, and at local levels. But we're not going to succeed on these issues without all of that engagement. One of the points I'd really like to make, and I think this is a perfect audience for it, and you probably know better how to activate this than I, which is that we're probably not going to solve these problems in the health sector alone. If you're talking about wanting to improve nutrition, increase physical activity, you're probably pretty quickly talking about transportation issues, the built environment issues, agricultural issues, marketing issues. So the second bullet just highlights that beyond health, involving these other sectors, housing, education, planning, are incredibly important. And I give you just one example, perhaps as an idea that you could use in your own work, and that is that at the federal level, language was put into the approps, not for additional money, but that directed USDA to work with CDC on increasing the effectiveness of the SNAP-Ed program. Now, we work a lot with USDA and we work a lot together, but that simple language directing the coordination of effort of the two agencies went a long, long way to our engagement and to their outreach and to our collaboration in developing some new activities under SNAP-Ed. Just one example, though, of the way that you might, through just simple language, require your state health departments and other agency sectors to work together on a number of these issues, and I think that would be incredibly helpful. And then as also saying, just focusing on the risk factors in the first place. Well, obviously we have certainly an enormous opportunity within our health systems to do a lot of good preventive work, and I think we definitely need to focus more here, particularly on the first bullet of making sure that the population as a whole has access to high quality screening in these issues. Screening for obesity starting at the youngest ages up through adulthood, screening for tobacco use and alcohol use, screening for high blood pressure, and as well as certain cancers. So, and of course that screening needs to be tightly tied to treatment and referral systems. I think a lot of times physicians are a little wary about asking about tobacco or asking or pointing out weight issues if they're not sure what they're going to do about that. Often there's not sufficient time to do intensive counseling and the like. We're working on a lot of connections between health systems being able to refer out to the community, be able to refer to the YMCA and actually have health systems paying the bill, so that individuals that are overweight or are pre-diabetic are able to be referred to ongoing services via the Y or other systems that the health system itself cannot provide. Issues like high blood pressure, though, we really need to get a handle on within our health systems. The control of high blood pressure is below 50% in this country. So it's a complete disconnect between the screening, the identification of high blood pressure, and then whether it is controlled at adequate levels, which is very cost effective. It's rather cheap and would optimally be arrived at through nutrition and physical activity, but there are excellent pharmaceuticals that can control high blood pressure and reduce the number of strokes and heart attacks in this country. The evidence is very clear. It's very cost effective. So, the screening, we just simply can't stop there. We've got to have, as the second bullet says, administrative and electronic and other systems of monitoring data out of these health systems so that we can tell in a given cohort, in a given provider system, that the individuals that are in that system are receiving optimal care and have these kinds of preventive services accounted for. Also, interestingly enough, we're doing a fair bit of work with maternity hospitals in the country to include their baby-friendly practices, meaning encouraging and helping new mothers breastfeed who are interested in breastfeeding. And the connections to childhood obesity are quite interesting. For each month that you breastfeed, the risk of childhood obesity goes down. In fact, if you breastfeed for 9 months, the baby's chance or odds of being an overweight adult are reduced by 30%. So there's some pretty simple and interesting things that can be done that meet the needs of patients and also begin to solve these problems. But basically, I want to talk to you, as you're well aware from your own experiences and those of your family and friends, that what surrounds us defines a lot about what we can do in terms of tobacco, nutrition, and physical activity. On the left here, you know, super attractive farmers markets or a wonderful bike path. Make it easy, attractive, accessible to engage in healthy behaviors. Whereas if we have, you know, our playgrounds locked and our food system, whether that's the vending machines at work or the available foods at school or in the community, if the healthy foods aren't affordable and accessible and easy to access, the choices are not supportive of health. So we don't always make it easy, and I think it's pretty easy to tell in your own life. I know every time I skip lunch and go running for something starving at 2 in the afternoon and the cafeteria is closed, my options aren't too pretty at that point. And so these are the realities. If there's not a full-service grocery in the underserved area and you've got a couple of kids and 2 bus routes to get there, it just starts to limit the kinds of choices that you have. But let's look first in terms of our community context about tobacco. I mentioned that we in fact know the kinds of actions that are effective in driving down tobacco rates. Perhaps they cannot be done everywhere, but we certainly have the data to show their effectiveness. This shows, I'm always doing that. This shows smoke-free indoor air policies in the country, with the darkest blue showing those states that have bans in work sites, in restaurants, and in bars. The yellow has a ban in 2 of those 3 areas, and the light blue are states, at least at this point in time, and I'm not saying this is accurate as of today, so I'm sorry if it's not accurately reflecting your area, but the light blue showing a less comprehensive or no ban in place. So what does this look like in terms of its relationship to smoking rates? And again, just a gestalt here. On the left are the 12 states with the lowest adult tobacco rates, and on the right are the 12 or so states with the highest adult tobacco rates. And this just color codes their smoking policy, so that on the left, those states with the lowest tobacco rates have the largest number of dark blue policy, meaning that they have the most comprehensive policies in place. Whereas if you look at the states with the highest tobacco rates here, their policies are either largely non-existent or weaker than the fully comprehensive policies. Now, can we say this is in any way causal? Of course not. You may have both smoking rates in locations for historical and population reasons, and also those are states where getting this kind of legislation through is extraordinarily difficult. But I think it's a fairly reasonable argument to say that the policy does hang with the tobacco rates in the country. Improving nutrition. I was going to talk just briefly about the other things that can be done in the tobacco arena. Those include, in addition to indoor air policy, and of course, looking at policies in areas like multi-house units and all is some of the sort of new territory that the country's looking at this point. But also looking at issues that increase price, reduce access to young people, work in the area of counter media, and of course make access to cessation available. So we have a 1-800-STOP smoking number that is free to anybody in the country that wants to call it, and we have very strong evidence of effectiveness. So this is the kind of information that if physician systems know that they can refer to these tobacco hotlines, for example, they may tackle the tobacco issue and make that kind of referral. We had tremendous success just recently. I don't know if you saw any of our TIPS campaign ads that were shown around the country, but we were able to use resources to put some pretty hard-hitting cessation promoting ads on, and the response to the cessation hotlines is immediate and very strong. So improving nutrition. There are so many avenues being tested here. Some of the ones that certainly look to be promising are the nutrition beverage the food and beverage standards in child cares, in schools, and in work sites. We've established nutrition standards for work sites. At CDC, we started with government buildings. Those are being widely adopted. Other people are beginning to use those for their own work site. We certainly can provide any technical assistance that any of you would need to promote that kind of work. Healthy food retail is a very exciting area of work with a lot of innovation going on around the country, including getting healthy products into corner stores and bodegas, especially in those areas that don't have full-service grocery, getting farmers markets into underserved areas as well as mobile farmers markets. In fact, some states have enacted legislation, of course, to be able to improve the incentives and attract full-service grocery and supermarkets into underserved, low-income, rural, and minority communities. There's been some work on improving public transit to the markets and supermarkets that do exist. And a lot of work in the area of state and local food policy councils. I'm sure many of you have those councils at hand that are thinking about all of these various strategies and what might work best for the locality or the state. Of course, increasing physical activity is a blend between motivating individuals to engage in activity, at the same time having localities that are safe, accessible, and attractive for that activity. So some of the work in this area are complete streets, where you really look to your transportation planners and engineers to consider the needs of all users, whether it's bicyclists, pedestrians, public transit, or motorists, as these new streets and upgrades are occurring. Street design for active transportation, your bike racks, your bike lanes, and the like. Increasing green space in parks. One of the things we're hearing an awful lot about, as I'm sure you are as well, are the safety issues associated with being able to be out of doors, to be in the parks, and to be using these spaces. So I think safety will be a big issue for us to tackle. Joint use agreements are quite interesting, whether you're working with shopping malls, particularly in areas with inclement weather, to have walking programs, or whether you're working with the schools for after school and weekend ability for the communities to use the school spaces. Zoning for mixed use, there's pretty clear evidence that when we build where we're blending residential, transportation, and commercial interests, that there's substantially more walking in those situations. Of course, in addition to this built environment arena, there's incredible work going on, and I think we're having a lot of success in the child care arena in terms of increasing activity, in the school arena in terms of increasing PE, and all of those are contributing to, I think, the flattening of the obesity rates that we're seeing, and hopefully the downturn moving forward. So I will just end here with another resource for you, which is that we produce a legislative database for you. You can again go in and pick a state, whatever state, or you can pick an issue. You can see whatever legislation has been put forward in the past 5 years, whether it has just been introduced, whether it has been enacted, whether it's dead, whether it's still under consideration. But you can, and if you see a bill or piece of legislation or regulation that interests you, you can actually go in and pick up that language to take a look at how it was approached. So we see each year more and more bills being introduced each year, and I'd say on average about 15% of these ends up in the enacted area with considerable focus on schools, work sites, and communities, as well as obesity and food councils being the major areas of legislation reflected in the database. Thank you so much for your invitation to join you today, and I think that we're going to hold questions actually until the other presenters. So